Welcome to The Deep Dive. We're the show that helps you get truly well-informed, cutting through the noise on really complex, important topics. Today, we're diving into something huge, something affecting millions, but honestly, often deeply misunderstood. Obesity. For way too long, I think, the conversation's been stuck on this idea of it being just a personal battle, just willpower. But that's such a tiny part of the picture, it really misses the mark. Obesity is, in fact, a complex chronic health disorder. It deserves a much, much deeper look. So our mission today is to move way beyond those simplistic narratives. We're going to explore the really intricate web of causes, the far-reaching health impacts, and maybe surprisingly for some, the diverse range of cutting-edge treatments that are actually available now. Think of this as your shortcut to really understanding a major...
Yeah, and I think starting with the sheer scale is vital. It helps frame everything else. Globally, obesity is linked to something like 5 million deaths every single year, and that's from non-communicable diseases, so things like heart disease, diabetes, not infectious stuff. Here in the U.S., the numbers are, well, stark. Excess weight was tied to nearly 500,000 deaths back in 2016.
500,000, wow.
Yeah, and get this, that's a higher excess mortality rate than smoking.
Really? Higher than smoking?
Higher than smoking. It just shows how profound this health challenge is. And it's growing. Prevalence shot up from around 23% in the late 80s, early 90s to over 40% just recently.
Those numbers are just staggering. And it forces you to ask, right? If the answer was simply eat less, move more, like we hear all the time, why are these figures so stubbornly high? Why do they keep climbing? It screams that this simple story is missing something huge.
Precisely. It's almost never just about that simple energy balance equation. That's really missing the point. Obesity is this complex interplay. So many factors, and many of them are, frankly, way beyond an individual's immediate control. Think of it less like a simple choice, more like a biological puzzle influenced by our DNA, the environment we're in, even things that happen really early in life.
That's a fundamental shift in thinking for a lot of people, I imagine. Can you give us some examples? What are these surprising factors adding to the puzzle?
Absolutely. Let's start with genetics. It's a big one. Our genes have a major say in how our bodies regulate appetite, how much energy we burn, even where we tend to store fat. Like abdominal fat, that fat around the middle that's genetically linked to higher metabolic risks like diabetes and heart disease.
Okay, so genetics sets a certain predisposition.
It does, but it's definitely not just our internal biology. The environment plays a massive role too, often in ways you wouldn't expect. We're talking about things like endocrine-disrupting chemicals, substances like BPA, in plastics. They can actually interfere with our body's hormones.
Right.
Even things like air pollution or taking certain antibiotics early in life can change our gut microbiome, that whole community of bacteria in our gut.
And that affects weight?
Potentially, yes. It can alter how we process food and store energy down the line. Then there's the impact of early life and development. This is profound. Things like a mother having obesity during pregnancy, or gaining excessive weight during pregnancy, or even conversely, restricted growth in the womb. These can actually program a child's weight regulation systems for life.
So stuff happening before you're even born or right at the start can set the stage. That's incredible.
It really is. And here's another connection that surprises people. Adverse childhood events, or ACEs.
The trauma.
Exactly. Stress, trauma, abuse. Studies have found really strong links, for instance, frequent verbal abuse in childhood, linked to an 88% higher risk of having a BMI over 40 later in life.
88%? That's huge. How?
Oh, it's not just psychological scarring. We think it involves neurobiologic changes in the brain, and even epigenetic mechanisms.
Epigenetic, meaning it affects how genes work.
Precisely. These experiences can literally alter how certain genes related to stress response and metabolism are expressed, changing how the body manages energy balance long term.
Okay, here's where it gets really interesting. This goes so far beyond just calories in, calories out.
Absolutely. And even fundamental things like sleep are critical. Not getting enough, say, consistently less than 6 to 8 hours a night can directly impact weight. It messes with your satiety hormones. Leptin, the hormone that tells you you're full, tends to go down. Ghrelin, the one that makes you hungry, goes up.
So you literally feel hungrier and less satisfied.
You do. One study even suggested that just dropping from 8 hours sleep to 5 could lead to a 3.6% increase in BMI over time.
Wow. Okay, what else?
We also have to consider medications. Lots of common drugs can cause weight gain as a side effect.
Like what?
Oh, certain antidepressants, corticosteroids like prednisone lithium used for bipolar disorder. The list is actually quite long.
Right, so people might be gaining weight due to a medication they need for another condition.
Exactly. And finally, we should mention specific eating patterns, things like binge eating disorder, which is actually pretty common, affecting maybe 10–20% of people starting weight loss programs, and night eating syndrome, where people eat a lot of their daily calories late at night. These are distinct conditions that contribute significantly.
It really paints a different picture, doesn't it?
Yeah.
It forces us to redefine obesity. It's not a character flaw, it's a disease. A complex one with roots in biology, our environment, our life experiences.
That's exactly the takeaway. And understanding that complexity is the only way we can start talking about effective and, importantly, compassionate solutions.
And the flip side of these complex causes are the consequences, which you mentioned are extensive. Can you walk us through how obesity impacts the body?
It truly affects nearly every organ system. Let's start with metabolic health. The link to type 2 diabetes is incredibly strong. Over 80% of cases are attributed to obesity. Then there's dyslipidemia, which is unhealthy cholesterol levels, and also MSLD, metabolic dysfunction-associated steatotic liver disease.
Fatty liver disease.
Exactly, formerly called non-alcoholic fatty liver disease. And it's serious. It can progress to cirrhosis and liver failure.
Okay, what about the heart?
Big impacts there. Cardiovascular risks shoot up. We see higher rates of hypertension or high blood pressure, coronary heart disease, heart failure, stroke, and even venous thromboembolism, blood clots in the veins. And it's important to note that central adiposity, that abdominal fat we talked about earlier, is an independent risk factor for these, even beyond just total body weight.
So where you carry the weight matters a lot for heart health.
It does. Then there's the link to cancer. This one is really alarming. Estimates suggest that around 0% of all cancers diagnosed in the U.S. in 2014 were related to excess weight.
40%, that's staggering. Which cancers?
Many common ones: endometrial, kidney, colon, postmenopausal breast cancer, pancreatic cancer. The list goes on. It's a major, major risk factor.
Unbelievable. What else?
Well, there are musculoskeletal problems. Osteoarthritis, especially in weight-bearing joints like knees and hips, is very common. Gout is also more frequent than respiratory issues. Obstructive sleep apnea is a huge one, very strongly linked to obesity, but also increased risk for asthma and something called obesity hypoventilation syndrome, which affects breathing.
Okay, and reproductive health.
Yes, significant impacts there too.
Yeah.
For women, conditions like infertility, polycystic ovarian syndrome, or PCOS, and abnormal uterine bleeding are more common. For men, we see links to infertility and erectile dysfunction.
It seems like no system is untouched.
Pretty much. Even our ability to fight infections can be compromised. Obesity can increase susceptibility to infections, including respiratory illnesses like the flu and, as we saw starkly, COVID-19. Obese individuals had almost a 50% higher risk of dying from COVID-19.
That's a huge difference.
It is. And we absolutely cannot ignore the psychosocial impact. Weight stigma, bias, and discrimination based on weight is rampant in education, finding jobs, even within healthcare settings.
Which must take a toll mentally.
A massive toll. It leads to higher rates of depression, anxiety, lower self-esteem. And interestingly, even after successful weight loss surgery, some studies show an increase in mental health disorders, self-harm, or alcohol use disorder in some patients. It highlights just how complex the psychological side is and the need for ongoing support.
Right, it's not just about the physical changes.
Not at all. And finally, there's the sheer economic burden. It's immense. Just in the U.S., back in 2017, the estimated cost was $1.4 trillion. That includes direct healthcare spending plus lost productivity from illness and premature death.
Trillion. With a T. It's clear the impact is just incredibly broad, touching every aspect of health, well-being, and even our economy. So, acknowledging all this complexity, all these consequences, what can actually be done? You said there's no single magic bullet, but a spectrum of options.
That's right. There's a whole range of evidence-based interventions. The main goal overall is to prevent, treat, or reverse the complications we just discussed, and fundamentally to improve quality of life.
Okay.
And it's really important for people to know that you don't always need dramatic weight loss to see benefits.
Yeah.
Even a modest loss, say 5 to 7% of initial body weight, can significantly improve things like blood sugar control and blood pressure. Though for substantial cardiovascular benefits, we usually need to aim for 10% or more.
Okay, 5–7% can already make a difference. That's good to know. Let's start with the foundation, lifestyle changes. Diet, exercise, behavior. What's the approach with diet?
With diet, the core principle, mechanically speaking, is reducing calorie intake to create an energy deficit. A common target is a deficit of about 500 calories per day, which typically leads to about a pound or half a kilo of weight loss per week initially. Beyond just calories, general healthy eating advice applies. Cutting down on sugary drinks, highly processed foods, trans fats, limiting saturated fats, getting enough fiber and water.
What about things like protein?
Ah, good point. Sufficient protein intake is really important during weight loss, maybe around 1 to 2 grams per kilogram of ideal body weight. This helps preserve muscle mass, which is vital because you want to lower fat, not muscle. Muscle burns more calories at rest.
Makes sense. And are there specific diets that work best? Keto? Mediterranean?
Well, there are many evidence-based approaches, balanced low-calorie diets, the Mediterranean diet, the DHH diet. They can all work. But here's the crucial thing research shows again and again. The single strongest predictor of weight loss success isn't the type of diet, it's adherence to whichever healthy eating plan is chosen.
So sticking with it is key.
Absolutely, which means it needs to be personalized. It has to fit the individual's preferences, culture, lifestyle. It really requires shared decision-making between the person and their healthcare provider.
What about things like very low-calorie diets or artificial sweeteners?
Very low-calorie diets, or VLCDs, can produce rapid initial loss, but they're hard to sustain and usually require medical supervision. They aren't typically a long-term solution for most. And non-nutritive sweeteners, well, the evidence on their long-term benefit for weight management is still quite mixed and debated. They might help some people reduce sugar, but they aren't a magic fix either.
Okay. Let's talk physical activity. How much does exercise really help with losing weight itself?
This is another area where there's some misconception. Exercise is absolutely crucial for overall health, heart health, bone health, mental health, and it's very important for preventing weight gain or maintaining weight loss. But on its own, physical activity usually causes only modest actual weight loss.
So it's not the primary driver of shedding pounds compared to diet.
Generally, no. Diet has a much larger impact on creating that initial calorie deficit needed for weight loss. However, exercise's key benefit during weight loss is helping to preserve that lean muscle mass and bone density we talked about.
Ah, okay. So it helps ensure you're losing mostly fat.
Exactly, which is critical for long-term health and keeping your metabolism from slowing down too much. The recommendations are usually at least 150 minutes a week of moderate intensity activity for general health. But for weight loss maintenance, keeping the weight off studies suggest much more might be needed, often 300 to 360 minutes per week.
That's a lot. Like an hour a day most days?
It can be, yes. Combining aerobic exercise like brisk walking or cycling with resistance training like lifting weights is usually best. But even just finding ways to be more active throughout the day, taking stairs, walking more, it all adds up and helps.
And underpinning both diet and exercise are the behavioral strategies, right?
Yes, absolutely essential. These are the tools that help people stick with the changes. Things like self-monitoring, keeping a food journal, tracking activity, weighing regularly. These are consistently linked to better outcomes. Also, learning stress management techniques, finding social support, maybe through groups or online communities, and using technology like apps or wearables can all make a big difference in reinforcing those new habits.
So lifestyle is the foundation. But for many people, it's not enough on its own, especially long-term. That brings us to pharmacotherapy or medications. This feels like a rapidly evolving area.
It really is. Anti-obesity medications, or AOMs, have become a much more significant part of the treatment landscape.
But they aren't just a quick fix, right? Who are they for?
Definitely not a quick fix. They're considered for individuals with a BMI of 30 or higher, or a BMI of 27 or higher if they also have weight-related health problems like diabetes, high blood pressure, or sleep apnea. And usually they're considered after someone has tried lifestyle changes for, say, 3 to 6 months, but hasn't achieved clinically significant weight loss, typically defined as at least 5%.
Okay. And what are these medications? Are they effective?
Some of the newer ones are proving to be highly effective. The most talked about are the GLP-1 receptor agonists and related drugs. You might have heard of names like Semaglutide or tirzepatide. These can lead to substantial weight loss, often in the range of 10 to 15%, sometimes even more, which is getting close to the results seen with some types of surgery.
That's significant.
It is. There are also other options like combination pills such as printermine topiramate or naltrexone bupropion, which have been around longer and can also be effective, though generally with slightly less average weight loss than the newer injectables.
What's the catch? Are there side effects? Do you have to take them forever?
Good questions. Side effects are common, especially with the GLP-1 drugs. Nausea, vomiting, diarrhea, constipation are the most frequent, particularly when starting or increasing the dose. Usually they lessen over time. And yes, this is a crucial point. These medications treat obesity as the chronic condition it is. They work while you take them. If you stop the medication, the biological drive to regain weight usually kicks back in, and people often regain much of the weight they lost.
So it's more like managing high blood pressure. You need ongoing treatment.
That's a very good analogy. It requires long-term commitment and, of course, ongoing monitoring by a healthcare professional, especially for people with other conditions like diabetes, to manage potential interactions or side effects.
Okay, so lifestyle, then potentially medication.
Yeah.
What if those still aren't enough, or someone has very severe obesity? What are the next levels of intervention?
For individuals with more severe obesity or when lifestyle and medications haven't achieved the necessary health improvements, we move towards medical devices and bariatric or metabolic surgery.
Devices, what kind of devices?
One category is intragastric balloons. These are non-surgical. A deflated balloon is placed into the stomach via endoscopy, a thin tube down the throat, and then filled with saline. It takes up space, promoting fullness and reducing how much you can eat. They're temporary, usually removed after about 6 months. They can lead to maybe 6–15% weight loss, but often there's regain after removal if lifestyle changes aren't maintained.
Interesting. Any others?
There's also a newer endoscopic procedure called endoscopic sleeve gastroplasty, or ESG. This is also done via endoscopy, but instead of a balloon, the surgeon uses sutures to reshape and reduce the size of the stomach from the inside. It's less invasive than traditional surgery, but more permanent than a balloon, offering maybe 13–20% weight loss at 1 year.
Okay, so minimally invasive options, and then there's actual surgery.
Right. Metabolic and bariatric surgery remains the most effective treatment we have for producing significant and, importantly, sustained weight loss, along with improvement or remission of many related diseases, especially type 2 diabetes.
Who's typically a candidate for surgery? Has that changed?
It has broadened recently, actually. Guidelines updated in 2022 now recommend considering surgery for individuals with a BMI of 35 or higher, even if they don't have other obesity-related health conditions. And also for those with a BMI between 30 and 34.9 if they have metabolic disorders like type 2 diabetes, significant hypertension, sleep apnea, etc.
So the threshold is lower now if you have related health problems.
Exactly. And for some populations, like individuals of Asian descent who tend to experience health complications at lower BMIs, the threshold might be even lower, starting around 27.5 with comorbidities.
What are the main types of surgery?
There are several, but the most common ones performed today are the sleeve gastrectomy and the Roux-en-Y gastric bypass, RYGB. The sleeve gastrectomy is actually the most common worldwide now. It involves removing about 80% of the stomach, leaving a smaller tube-shaped stomach or sleeve. This physically limits food intake, but also reduces hunger hormones produced by the stomach.
Okay, and the gastric bypass.
The Roux-en-Y gastric bypass works in 2 ways. First, it creates a very small stomach pouch about the size of an egg, which restricts intake. Then it bypasses a significant portion of the stomach and the first part of the small intestine.
So less absorption, too.
Yes, there's a component of malabsorption, meaning fewer calories and nutrients are absorbed. RYGB tends to lead to slightly more weight loss than the sleeve on average, and it's particularly effective for putting type 2 diabetes into remission. Studies show remission rates as high as 62%, even 6 years later. It also significantly reduces long-term mortality from cardiovascular disease and cancer.
That's remarkable. Are there other types?
There's also the biliopancreatic diversion with duodenal switch, or BPDDS. This is a more complex surgery, usually reserved for individuals with very high BMIs. It involves both a sleeve gastrectomy and bypassing a much larger portion of the small intestine. It leads to the greatest amount of weight loss and the highest rates of diabetes resolution, but it also carries a higher risk of nutritional deficiencies and complications due to significant malabsorption. Requires very careful lifelong monitoring and supplementation.
So these are powerful tools, but definitely not simple procedures. What are the outcomes generally like?
The safety profile has improved dramatically over the years. In-hospital mortality is actually very low now, around 2.08%. And the long-term benefits are substantial. Overall mortality is reduced by about 25% compared to similar individuals who don't have surgery, mainly due to reductions in deaths from heart disease and cancer. And as I mentioned, remission or improvement in diabetes, high blood pressure, sleep apnea, fatty liver disease is often dramatic.
But it requires serious commitment, right? It's not just the surgery itself.
Absolutely. It's crucial to understand these are not easy outs. They require extensive preoperative evaluation, psychological, nutritional, medical. And afterwards, it necessitates major lifestyle changes and lifelong commitment. This includes regular follow-ups, taking vitamin and mineral supplements indefinitely, especially with bypass procedures, to prevent serious nutritional deficiencies. It's a life-altering intervention with incredible benefits, but it demands adherence to the post-operative plan.
It's also interesting you mentioned they're being considered more in younger and older populations now.
Yes, there's growing evidence supporting the use of bariatric surgery in adolescents with severe obesity, and also in older adults, populations where it was previously used more cautiously. The data so far suggests favorable risk-benefit profiles in carefully selected patients in these groups, too.
This really highlights the spectrum from lifestyle changes all the way to major surgery. But what about keeping the weight off? That seems to be the perennial challenge.
It absolutely is. And this comes back to understanding obesity as a chronic relapsing disorder. Our bodies are actually hardwired to defend our fat stores. There seems to be a biological set point for body fat. When you lose weight, especially through diet alone, a whole cascade of counter-regulatory mechanisms kicks in.
The body fights back.
It fights back hard. Hormones that regulate hunger and fullness change. Ghrelin, the hunger hormone, tends to go up, while hormones that signal fullness, like leptin, go down. Your metabolism, the rate at which you burn calories, also tends to decrease more than you'd expect just from the weight loss itself.
So your body is basically trying to push you back to your previous weight.
That's a good way to put it. It's a biological resistance. This is why long-term maintenance is so difficult and why studies show that most people who lose weight through diet alone tend to regain a significant amount, often within 3 to 5 years if they don't have ongoing support or intervention.
So what does this all mean? For you, our listener, trying to make sense of this, it means understanding this biological reality, this resistance is absolutely crucial. It helps explain why simply trying harder often isn't enough. And it underscores the need for effective, empathetic, long-term management strategies, whether that involves continued lifestyle support, ongoing medication, or the permanent changes from surgery. It shifts the paradigm away from blaming the individual towards a more sustainable medical approach to a chronic condition.
Exactly. To sum it all up, obesity is this deeply complex, multifactorial disease. It is absolutely not a simple failure of personal responsibility or willpower. Effective management really demands a personalized, comprehensive approach. It needs to integrate lifestyle changes, potentially anti-obesity medications for the long term, and sometimes surgical interventions all tailored to the individual's needs and health status. And critically, it requires recognizing this is often a lifelong journey.
Which leads us to a final thought for you to consider. Given everything we've discussed, how profoundly our biology influences weight, the huge range of factors involved that are often beyond our immediate control, from genetics to childhood experiences to environmental exposures, given all that, how might we as a society need to rethink our approach? How can we evolve our support systems, our policies, maybe even our attitudes to truly empower individuals on this lifelong journey toward health and well-being, instead of just placing the entire burden squarely on their shoulders? Something to mull over. Thanks for joining us on The Deep Dive.